Welcome to docsTALK, where complex medical topics
become easy conversations with me, Dr. John Martin.
And me, Dr. Brianna Walton. So come on over to AAMC and get a dose of the doc. Hello.
You look gorgeous.
Thank you.
Welcome, everybody.
Welcome back.
Tonight, we're going to do another episode of docsTALK, where we try to take complex medical subjects and turn them into easy conversations, as we like to say, to go from the emergency room to your living room. And you walk away tonight with some helpful information that you find that this evening was well spent, and holy smokes that we got a full room tonight.
We have a full audience.
So if this is how many of you this is the first time? Oh, we do have some
Wow, we have a
newbies.
lot of probies in the audience.
Wow, where have you been? We've been doing this for 2 years. Well, for you first-timers, my name is John Martin. I'm a vascular surgeon here at Anne Arundel Medical Center.
And I'm Brianna Walton. I'm a urogynecologist. I'm the director for the Women's Center for Pelvic Health.
Or, as it can be said, it's Beauty and the Beast. You know, I think this is another new outfit, isn't it?
Of course.
So I recently heard that Vanna has done, I think, about 6,000 shows and has never worn the same dress twice. Is that your plan?
I don't plan on getting 6,000 outfits.
Not in the budget?
No.
Well, this is an exciting show tonight for us. We're going to talk about aging intelligently or wisely, and you know, there's a lot of this subject that is near and dear to all of us. As you can look around the room, I see a lot of people walk through the door and hope that we're going to have the answers. I'm not sure we will, but we're going to make it interesting.
You know, the last time I talked to our producer, Jana, she said our count was somewhere around 250, but it looks like well over 300 to me.
300 folks. What's the record? Do we know? I think we beat it tonight. I think
may
this may
have.
be the biggest
Congratulations.
crowd we've ever had. Good for all of you. I do want to make a quick shout out. He's going to be mad at me for doing this, but I'm going to do it anyway because so much of this institution is really his vision. And I did see Chip Dorden here, and I know he's going to be mad that I mentioned him, but in the audience, please a big round for the man who this campus is a vision of.
Absolutely.
So aging wisely, when I think about that, you have to think about a lot of different aspects of this. And for me, it's about taking care of my body, and I'll quickly bring up the fact, and we have Dr. Sutter and my coach here about diet. And for those of you that have been here all along, B and I started this diet program in October, and now I'm down 30 pounds and a new me. So the body is obviously
my weight. Thank you.
The downside of that is you got to buy new clothes, which is bad. And I'm trying to keep up.
And you talked about my outfits.
I know. So it's your body, and for me, it's staying connected to friends and family, and for me, the community is a big part of that. And staying engaged and tackle every single day for what it can be for you.
Well, I think that one of the more important things for me, I may be one of the younger people here tonight, but it is about aging wisely. So I want to stay active. I want my family to be active. So whether you're young, you're old, you're a senior, you're going to be a senior, or you're taking care of your parents, this is a hot topic tonight. So we're all going to be paying attention.
Well, that's good. And I think we've made this so important that we've kind of broken the pattern of the show. Typically, as those of you who've been here, we have 2 experts. Tonight, we have 4 that we're going to bring to the stage. And we're going to deal with the mind, the body, your medications, and a very difficult subject for all of us to deal with, and one that's critical for the future of healthcare in this country, and that is dealing with end-of-life issues.
Well, my plan is to grow old gracefully. And so it's very helpful for us to have all these topics, primarily because I want to keep my mind active, I want to keep my body active, but those conversations that you're alluding to, I need to be able to have those with my family members. I also need to be able to help them manage their medications, because some of the things I'm not necessarily familiar with as a urogynecologist.
Oh, here we go. So we're going to get right into the experts because we have a lot to cover tonight. So we're going to start this, though, with a cute little piece. And you'll find we're going to take some poetic license with some things tonight. So if we offend a few people, please know that this is all done in good taste.
Yeah, and send your complaints on a $100 bill.
Who are we addressing that to? docsTALK Wardrobe Department. That would be perfect. All right, the first clip you'll see is really a great example of this entire show and why it's so important to live every day and to age wisely. Let's run it.
on that one, John. That's really, doesn't that about sum it up? I mean, that was a little too fast.
Well, thank you everyone for coming. It was a nice program.
So on that note, we'd like to bring out our first guest, Dr. Andrew Dobin. Please join us. Hello.
Thank you.
Welcome.
Hello, my friend.
Thank you.
So you're our mind guy, and you're going to explain to me why I absolutely have no earthly idea where my car keys are, and whether or not they are located the same place as my remote, and whether that's signs that I got to be concerned about the aging process and what effect it's having on my mind.
Well, thank you for having me, and that's a great question. On that topic, I wanted to congratulate all of you for coming here tonight. Since you mentioned Mr. Dordan, I know when he designed this health science building, his goal was to give us all a mental status exam. And he made this maze of a hospital. So, for all of you to get here tonight, you had to remember whether to park in parking lot D or E, whether to find the first elevator, take it to the second floor, walk across, find the other elevator, and get to the 7th floor. So the good news, if you did all that tonight and got here, you probably don't have dementia. And if you got here from the Sajak Pavilion, oh boy, you're really good.
The Mensa meeting is next door.
But you're probably all thinking, I'm sorry.
No, keep going. I think you're going right in the right place.
You're probably all thinking, yeah, I did get lost the first time. But you were able to remember that you got lost and to process that and bring it back from your memory how to get here. But you're still thinking, as John said, where did I park? And I think parking, to show the example, that's probably part of normal aging. When you were parking, you were probably thinking of something else. I'm hungry. Well, I have time to go to the bathroom. What am I going to eat later, et cetera. And you probably didn't process at all where you were parking. And this parking lot looks like every other one. And I'll admit, I wrote down on my cell phone where I park because I can never remember where I park.
Do you have dementia?
No, I think I have normal aging. So what are other examples of normal aging? And I think everyone here knows them. It's remembering words. So words we don't use all the time. It just takes a long time to get it out of our brain. Names, especially names that aren't all that important. Someone you see at church once a month. That movie actor or this movie you really love, but you just can't remember it. It's more it's where did I put the remote control? That's kind of normal aging. Not remembering how to use a remote control, that's more serious.
That's a good point.
What if I never knew how to use it in the first place?
That's why we have children.
Okay. So the distinction really between normal aging and dementia can be difficult then, is what you're telling me.
It can, and what makes it more difficult is there's a new category called mild cognitive impairment.
That's a mouthful.
It is.
That's called Congress.
Yes.
No.
That's severe impairment. So when we don't go from normal aging to dementia overnight. There's steps, and often people come in and discuss their memory, and there's something just a little bit more serious. An accountant who can no longer write a check. Or you forget someone important. And we know the good news is that doesn't always go to dementia, but there's a rate of about 10% a year of people who have some mild cognitive impairment who go on to dementia. And I think that's where our focus of research should be, to try to keep the people who have only mild deficits from getting more severe.
That's a good point. Well, why don't you start us off by talking about some of the signs and symptoms? I think you had a slide for this. I mean, one of the things that, in our own concern is that, I forget words, and is that related to just being tired, fatigue? I mean, you can go ahead.
Well, I think that's a great point. And a lot of those things are the mild things like you might be from fatigue or lack of sleep or multitasking. But when is it more severe? Well, the key thing is Alzheimer's. And I want to do one thing I forgot is dementia and Alzheimer's are not synonymous. There's a whole field of dementia, and Alzheimer's is just simply one kind, though the most common, 80%. I think tonight we'll talk about Alzheimer's, but there are other kinds. But when someone has Alzheimer's, it's just not memory loss. And I think that's the key thing. There are other features. It affects speech. I don't mean just forgetting a word, but speaking fluently. It's not just speech, it's also recognizing things and thinking. Again, to the example, being able to write a check, that takes thinking. It's not just remembering where you put the checkbook, it's how to use it. But for Alzheimer's, it has to have several different domains of thinking and memory and speech, and also has to affect just your ability to do your everyday activities.
So we've got some others up here, planning and organization, behavior disorders. What does that refer to, and what specifically? How would you recognize behavior that is symptomatology of maybe Alzheimer's or dementia?
Well, often people get withdrawn. They don't do as much activities. They might not come out to something like this because they're embarrassed because they might get lost. But then, more than that, they may not engage with other people. A thing very important to look at is depression. And I think that was one of the topics we were supposed to talk about, but depression is very common in Alzheimer's, and it needs to be treated because depression on its own affects people's memory, their ability to process, think new things, and enjoy things.
Delusions, how would they recognize a delusion?
That's a great question. Delusion is something, and this is more severe. Obviously, we're getting into the later stages. A delusion is they might think their dead spouse is there. Or they might, an hallucination is seeing, a delusion is thinking something. So they might think someone is there who's no longer there, or people are coming to their house, or the laundry machine is some kind of bomb because they hear something.
Okay. So how, if we look at this and we see signs and symptoms, is there a test? I mean, is there the Alzheimer's or dementia test? So people can say, okay, I think my husband or wife has these things and I'm concerned, can I get the test?
Unfortunately, the answer is no. And I think that's a great question. But we're still good in diagnosing it. When you see the doctor discuss memory loss, they often do some blood tests. Well, the blood tests are not to specifically diagnose Alzheimer's, but to rule out some other things like thyroid disease or B12. You often do a CAT scan. There's no specific change on the CAT scan, but we want to make sure there's no strokes, another cause of dementia, or just to look at the sign of the brain. But a doctor taking a good history of a slowly progressive memory problem, and I want to make a point that it's really, really important to have a caretaker, friend, spouse there. You can't ask someone who has a bad memory about their memory.
Right.
And also, as people have memory problems, they kind of lose insight into their problems. Most of the time, they deny there is a problem. So it's very important that someone is there. And I think the most important thing is talking to a family member. But I think if you rule out these other diseases and take a good history, we're very good at it. There will be new things in the future. There are PET scans coming out. And I think we'll have PET scans soon where you can inject something that will light up the specific tangles in the brain, which are made of amyloid, not to get too scientific. And we'll be able to light those up in 10 years and say, this person has Alzheimer's. But it doesn't really change our treatment now, so we're not doing those tests.
So speaking of treatment, are there medications that you like to use? I mean, depression, obviously, you want to treat, okay? But what about specifically for Alzheimer's or dementia?
Yes, they're medicines, but it makes me sad to say in 2013 that they're not very good. You're probably all familiar with Aricept and similar medicines, and they slow the progression of the disease. But I think it's very important to know they just do a little bit. They slow it slowly, and I think it's important for people to have realistic expectations. Are they worth it? Sure, because if someone can stay home in their house versus go to a nursing home, it's worth every cent. But it's really important to have realistic expectations of how good they are, and often we need to stop them because they can give diarrhea and other bad side effects.
So are there risk factors that we can be aware of that should make us concerned that the people could look out for, that, hey, I'm at high risk or not? Is there a genetic role to all of this?
Well, as far as risk factors, there are some risk factors, and John, they're very familiar to you because they're the same risk factors for vascular disease. So we know that smoking is bad, and high blood pressure is bad, and diabetes is bad, and being overweight is bad. So I can't prove that if everyone took care of those problems, they wouldn't have Alzheimer's, but they wouldn't need John Martin to operate on their carotids if they did all those things. There are some genetics. There's one gene out there we know of, and To not get too technical, it's called the ApoE gene. It's not really used in clinical because it doesn't totally predict the disease, and I don't encourage my patients to get it.
So, this is not something that we're concerned about, it being depressing, hearing these subjects where you have progressive disease and memory loss. Are there things that we can do to try to prevent it on our own? You already mentioned medications aren't really that effective, but what other things can we do?
I think that's another great question. And so I looked at a couple research studies. The best one I found was out of the Bronx, for you New Yorkers out there, from the Einstein Hospital, where about 10 years ago they looked at 70-year-olds in the community. And they looked at what activities they did, and then they looked later who got dementia. Now, it's not a perfect study because there's always a chicken and the egg, what comes first. But I thought it was interesting what activities were protective. If your parents made you take a musical instrument as a kid, you should thank them and take it back up. That was the most protective thing, playing a musical instrument.
Thanks, Mom.
Get back on the piano is what
So I've actually started again.
Okay, good.
Another one was playing board games. It's an old study. I don't think there were video games, but playing board games and probably crossword puzzles and Sudoku, etc. Reading was very good. I thought this was interesting. Of the physical activities, dancing was the best.
Excellent.
That makes some sense because it takes all parts of the brain to dance, coordination, musical skill, repetition, etc. There were a couple of things that were not protective. So if anyone needs excuses, here they are. Housework was not protective, nor was babysitting. So when your kids call, tell them you're out dancing.
And you're preventing your dementia.
That's right.
I think the point with all of these, though, and I think we have a little fun with them, but the bottom line is you have to exercise your mind. It really isn't any different than exercising your body, and those are all activities where you exercise your mind. And if you struggle to dance like I do, it is more of a mental thing than a physical thing. Right. To try to keep off our toes. So I think the key thing here is put your brain to work. Don't just plant in front of the television and watch
Good
Dr.
point.
Oz, because you can come here, clearly.
Amen.
You don't need to do that.
Amen.
Yeah.
All right.
Well, I think these are important topics. We got a lot of folks up here. We're going to get more into this in the breakout session, but we appreciate you getting us started, and we'll get more from you at the breakout session at the end of the show. Thank you very, very much.
And I just wanted to say, because of this, I've started to learn how to play bridge, so if anyone can help me during the breakout session, I would appreciate it.
All right, well, our next guest is a frequent, well-known person here, and the guy's in charge of my weight loss, Dr. Fred Sutter.
It's great to be back with you both.
Yeah, welcome back, Coach.
Wonderful. It's wonderful.
We're happy to have you. I mean, we know how important it is for us to live healthy and eat healthy. You've taught us that. One of the things that Dr. Dobin focused on is our mind healthy, but we know we've got to keep our bodies fit. So we want you to share with us some of your pearls of wisdom.
Thank you. It's interesting that fitness is a very key feature of anything that goes along with preventing any aging disease, whatever body part you're talking about. And I would like to think it's more like prevention rather than dementia. And I was fit enough to run up and down the different levels of the parking lot when I got lost. So I was fit enough to compensate for that. So I think that's an important feature of survival, is being fit enough to compensate for that. I still get lost just about every time I come in. But some basic things are, it always starts with the food. What kind of fuel you put in the tank, so important. Doing routine exercise, and we'll talk a little bit more about that later. And managing your stress. Stress is a huge drain on many people. They stay up too late, they do crazy stuff that they really shouldn't do, and I think stress management is a key feature in managing their long-term, prospects for keeping your mind healthy in the long run.
So I'm curious, with a show of hands, how many of you in the audience actually exercise regularly?
Oh, yeah.
That's pretty good. All
Healthy folks
right, now
here.
how many of you are counting walking the dog as that exercise?
It depends on the dog, right?
There's one. I'm sorry, he stops every 2 feet. That does not count.
to walk and a sniff.
All right, well, one of the questions here, and we got a great broad range of people here. At what age do you start thinking about, okay, I've really got to get into this diet, exercise thing to plan for my aging process?
Whatever age you manage to think of it.
The delivery room?
Probably is a good, like the guy in the movie, he's starting from the beginning. No, I think that there's no age that's too early to start this, especially today with children. I mean, you almost have to boot them out of the house. They're so locked onto their electronic equipment. So I think creating healthy lifestyles that carry you through your lifetime is more important than anything else, because it's a whole lot easier to maintain a program than it is to start one. But the good news is that the body is extraordinarily forgiving. And when you do decide to change some things in your lifestyle choices, it makes a huge difference, even if you think it's been too far. For example, Rosenberg and Evans up at Tufts studied people in their 70s, 80s, and 90s, and they found that the people who were in their 90s who were most successful exercised routinely, and one of their particular features called biomarkers that was most predictive of successful aging was their lean body mass or their muscle. So exercise is extraordinarily important.
So we know there's no too early. Is there a too late? And when I say, okay, I'm already 80, why should I bother starting now?
No.
What's your answer to that?
Never. It's never too late. I've seen tremendous turnarounds, and people have had strokes and terrible diseases, and they do one little step at a time, and they slowly get onto it. Sometimes it takes an act of Congress, which is mild cognitive, impairment. But it really makes a huge difference in people's lives. And I've had people with strokes who take it as an adventure, especially with the food. Now, the exercise is a different story. So one of the things you can do to motivate you, because every action is usually preceded by an intention, is to get on a website called realage.com. And it sounds like everybody knows who Dr. Oz was, but back in the day, before Dr. Oz was Dr. Oz, he and Michael Roizen did a lot of homework. And they predicted what lifestyle choices made the biggest difference in keeping you at a certain age or less. So that's a good motivator, because once you do that, you'll find out maybe I'm a little behind the 8 ball, so that'll stimulate you not to play it off until later.
realage.com.
Everybody get that and write that down.
All right.
Realage.com.
One of the things we talked about before the session was the term sarcopenia. So I wanted you to explain that to the audience, if you don't mind.
That's a great word. In the visual you have that's going up, this was actually coined by Rosenberg back in the late 80s. And you'll see that on the individual on the left, they're both about the same shape and size, but one has a whole lot less red, which represents muscle, than fat, which is represented by the yellow. Sarcopenia is from the Greek root sarkos, or flesh, more specifically muscle, and penia meaning deficiency or insufficiency. So you can see that the individual on the left's in a whole world of trouble. Maybe they were the one who did the crash diets and lost a lot of weight, and usually when you lose a lot of weight real fast, you lose muscle right away. So they may be the same shape and size as the one on the other side, but the one on the left is going to age much more rapidly. And if you're worried about shape, which some of us are, you want to look at the 5-pound representations on the right, where it has muscle being a whole lot smaller at 5 pounds than the fat. So if you want to look a little bit more svelte, then you want to develop your muscle.
That's a good slide. Thank you for sharing that with us.
So key foods for people to start thinking about if you wanted to kind of break down, and I know there are a million diets out there and a lot of different recommendations.
Yes.
Can you give some basic
Just
stuff that people
focus
can
on
go
the
by?
basics. The basics are, first of all, you can't eat too many vegetables. They are the antioxidants that prevent aging in the long run, and that's how we live in this environment. The second thing is I suggest people just focus on eating an adequate amount of protein. Protein is the key building block of making muscle. So I think that's somewhere you should focus first, along with the vegetables, and eat all them first, and then the carbohydrates, the more refined stuff, will fall into place, like grains. Other protein sources would be beans and legumes, tofu, if you know how to spell that, and nuts, certainly. They have to watch the calories with nuts. So these are very, very important things.
Is there a specific amount of protein that we should be getting in our diet?
Absolutely. Once you hit, now I don't know why these numbers turn out, but once you hit about mid-teens, for women, you need about 46 grams per day. I don't know why they couldn't come up with 45. It's a whole lot easier to remember. And for males, it's 56. So once you're at mid-teens, and you do a protein gram count, that's grams, and it's all listed on the information slots on all the foods that you eat, you'll see how many grams you're really getting in a day. And after looking at literally tens of thousands of diet logs, most people are not getting adequate protein.
Interesting.
Yeah, how much grams of protein are in an Oreo cookie?
Not enough for you, John.
Just checking, just checking.
Well, I'll give you an example. 3 ounces of like a pretty lean meat has between 20 and 24 grams of protein. A cup of beans, dried beans, has about 15 or 16 grams. That'll give you a
So we got to work at it. I think most
Yeah.
folks are falling short on that. I think that's tough.
Absolutely.
So I'm at the gym every day, or try to, when life doesn't get in the way, and I make resistance training a big part of that for me. Is that something that all these folks should do as well? Do they need to be this is the future Arnold Clinic of America here in front of us?
Arnold. I don't know what that means, though, the Arnold Clinic. That could mean a lot of things out in California. The one thing that we know for a fact is that those people who survived successfully and healthily into their 90s did do some sort of physical resistance exercise. Now, it may not have to be in the gym, but as you know, President Reagan used to chop wood even when he didn't have to. He had very large arms for his age, and that's a key feature. So, and the thing is, John, at your age, I think you get credit for just getting to the gym. You know?
Dr.
Excuse me, let me move my walker over here.
No, the point being is, like, I don't really feel like going to the gym. 99 times out of the 100, once you get there, you're going to feel, it's like, all right, I'll just do one thing. And then you do 2 things, then you do 3 things. And you feel a whole lot better when you're done because you're probably a little bit more kind to yourself than beat yourself up, did what you needed to do that day, and then got home.
So does the resistance training kind of tie back into the sarcopenia slide that you showed us with more lean body mass?
Yes, you have to put resistance or load on your muscles to build more muscle. Okay. So if I were starting at some late date or had a pretty serious illness where I lost a lot of muscle mass, you'd have to do some resistance. Now you have to be careful with that, and your doctor can help you with what choices of exercises you would consider. But based on your injuries, what have you, you have to do some resistance training. Now, the question is, nobody's going to go into the gym after being 60 years on the couch, but they can start with simple things, very, very simple things at home.
Like what?
For example, well, what's the greatest risk for the elderly is a fall. I think that's been documented many times.
Yep.
And what do you fall from? Do you fall from the throw rug that was inappropriately placed, or do you fall from the fact that you couldn't recover when you tripped? And a lot of times that's a combination of coordination, maybe some eyeglass issues, but almost always it's from leg strength. And leg, buttock, and back strength are the key features of keeping people out of nursing homes. So if you really want to stay out of the nursing home, do some squats every day, partial squats. And I won't demonstrate here, I'll demonstrate in the breakout session, but you can hold onto a chair, put a chair underneath your rump, and just start doing partial squats really,
So a
slowly.
squat means just sit down, stand up?
But not all the way down. If you have a bad knee, you might find that out really quickly. But go partially down. And I have my patients start with just a little bit first. And you have to go to the point where your legs get a little shaky. And then it's probably time to sit down.
Well, that's a good point. If somebody does have like back pain or knee problems, they can still do the partial squat and not really hurt themselves, correct?
Absolutely, yeah.
Okay.
Or they have to get into the pool. I mean, you have to be flexible as you age. Like I used to like doing running, but running was taken out back in the 80s for me with an injury. So you have to be adaptable and learn to like the new thing as long as you stay in the gym. Be flexible, be adaptable, and just get yourself to the gym. That's the key feature.
When would you say, though, that the aging process actually starts? I mean, based on that video, you come out of the womb and darn it, it's over.
Now, it depends on what body system you're speaking of and how rough you were in your body. We know that from the musculoskeletal point of view, you stop doing the growth factors somewhere in the late 20s, early 30s. But if you were really mean to yourself in your developmental years, you might have stopped a lot earlier. So somewhere in your 30s and at least in your 40s, as everybody knows, I see enough people in here who know that, you should be really committed in your 40s. A lot of times family responsibilities get in the way of that, but that should be part of the example you're setting for your children and booting them out from in front of the TV or the computer.
Well, I certainly know from those of you who saw the paper this week, we had Roger Staubach on the football field, and at age 71, he was chasing all of us around the field and could still play. And the big part of that, as we talked with him, was he has a regular exercise regimen that he does on a daily basis. He watches his diet very carefully and basically follows all the recommendations that you just gave, and it was very evident on that field. He still threw the football 30, 40 yards down the field like it was nothing. So clearly evidence that if you actually do the things that you're talking about, even into your 70s and 80s, you can still get up and play.
Oh, it's easier to keep the train rolling once it's going. But don't give up hope. I mean, I've seen the body's extraordinarily forgiving. I have no problem with starting somebody as old as they want to start.
Well, we look forward to you leading the charge in the breakout session. We'll get some more information from you, but thank you.
Great being
Good to
here.
have you back.
Thank you.
Thank you so much.
We're gonna go to-
So, how many of you are on multiple medicines? How many of you struggle to get that right? Well, we've got some advice for you.
Well, we got some smart people in the room. We'd like to bring up our next guest, Dr. Tamiko Bryant. Please join us.
Hi.
Welcome.
Thank you.
Welcome.
Thank you very much.
Thanks for joining us.
Thanks for having me.
All right, so what's the magic number? As people age, what's the typical number of medicines? These guys want to know, am I normal or abnormal for the number of pills I take?
The approximate number of medications that people 65 and older take range anywhere from 6 to 9 medications
That's a
per
lot.
day.
That's a lot.
And that's out of the approximate 1.8 billion medications that are prescribed during the course of a year. And with the 65 plus population averaging about 13 to 15% of the total population.
So,
So how many of you are on 6 to 9 medicines in this room? Wow. How do you have room for food?
well, we know that this area is really important. I mean, managing medications is a big topic, not only outside the hospital, but in the hospital too. So what are your primary concerns or issues that we need to focus on tonight?
I think there are 3 primary issues that are of concern. The first one is, as people get older, the severity of illness tends to increase. The second point is there tends to be new medical problems that tend to occur. And the third is you're receiving medical care from multiple providers. And sometimes the communication gets lacking in terms of any adjustments in medications
That's
or
key.
additions or subtractions of medications.
That's really
So are there great safety tips that we can give these guys on how to manage the pharmacy cabinet that's in their house?
Yes, there's several. One you can consider is trying to watch how you store your medications, being knowledgeable about your medications, the possibility of interactions with the medications. When should you not take medications? When should you also watch how you're taking them in terms of doubling up on a dose or not, and avoiding certain foods and alcohol with various medications.
Side effects is a big thing. You know, you start on a medicine, you feel something funny, it must be the medicine. And we get that a lot. And I don't think that there's a medicine out there that doesn't have a side effect.
Correct.
And so how do you suggest that they manage side effects? Should they call their doctor immediately? Should they keep taking it for a little while to see if it goes away? What kind of advice would you give them with regard to that?
Well, first off, I think it's really important to contact your physician if you notice anything that's out the norm when you're taking medications. Some things that will help to facilitate your visit with your provider would be to mention the medication that you think might be in question. When do the side effects occur with the medication? What is the nature of the side effects? How long did they occur? How long did they last? How long did you take the medication before the side effects started to occur? So all of those pieces of information are helpful, as well as, does this medication already have a known side effect associated with it to cause a side effect that might be of concern?
Well, I think on your slide set, I mean, the next couple about mixing with over-the-counter meds and herbal supplements is something we need to focus on because sometimes there's side effects from the supplements.
Correct. One thing you definitely should not do when it comes to herbal medications is you do not take herbal medications for which a prescribed medication has been already given. What tends to happen is you compound the potential risk for side effects as well as adverse issues with the medication itself, being it making the level of the drug too high or rendering it ineffective.
So Tamiko, give us an example of one, like what they shouldn't do.
Well, one herbal supplement, just to give you an example, there's a supplement called red yeast rice. The issue with red yeast rice is it's actually the active ingredient in most statin medications. Now, if you're on a statin drug, then you don't need the red yeast rice because you are compounding the likelihood that you may have the adverse effects of muscle aches or pains, Sometimes constipation is dose related with a lot of the statin
That makes
medications
sense.
as well.
So are there any tactics, I think, that people can employ? I mean, what role can the caregivers or their partners play in actually helping them manage medications?
Okay, it's really helpful to have people assist you with your medications if you have any questions. First of all, it's imperative that you know what your medication is and actually what it's for. Then you can get into how it should be properly taken. If you need some help with multiple dosings of a particular medication, you can actually use a lot of those medication boxes. They're starting to make them pretty fancy these days where you
Right.
can have 4 times a day dosing if your medication requires that. So that's really helpful, and just really keep informed with your doctor or in communication with your physician so that you all can make the best decisions.
Well, just in counter to that, a lot of people get information from the internet. So how do you parlay that into their everyday processes? I mean, there's a lot of information there.
Yes, the internet is helpful, but you really have to be careful because everything is not as accurate as it seems. I still would say your first resource should be your physician. Your physician can help guide you in terms of what resources may be the best to pursue to get the answer to the question.
Okay.
Also, your pharmacist is an invaluable tool as well because they'll have a lot of access to various interactions with medications.
So one of the things I see with patients that come to see me that's incredibly helpful when it happens is obviously carrying your medication list for every doctor visit. But you should have down there, this is my medication, this is what the dose is, this is how often I take it, this is what I'm treating, and this is who gave it to me.
Right.
So that you can actually have a very nice list of that. And that helps us actually manage between folks. And I will tell you, probably less than 10% of the people that come into my office have that kind of list. And that's incredibly helpful and will start to keep you out of that problem of who's prescribing what and who
Good
needs
point.
to adjust what, and to have that with you each time.
Very
And
good
it's
point.
also really helpful too to have any list of supplements or anything vitamins or anything like that you're taking as well. That should be on the front end of the communication. That way, pretty much you have an even playing field about this is what I'm taking, this is what interactions I could potentially have as a result of taking this combination of medications.
So a lot of people on supplements. Is there a point where you're taking too many medications and you shouldn't be on supplements, or is there always a role for both?
There may be a role for both, depending on what you're trying to address with the supplement. I still say you should first keep your medications that are prescribed as your primary basis, and then you can add or subtract as necessary. And your doctor, again, would be a good resource to help you determine what supplements are necessary and what are not.
How many of you out there are taking supplements on a regular basis? Put your hands up. Wow, look around the room, guys. Well over, probably 2/3 of everyone's on some kind of supplement. That's interesting.
So you mentioned, John, a lot of patients don't actually come in with their list of medications and their supplements. So talk a little bit about drug interactions, because sometimes it's not just a side effect, it's the two medications together that actually causes a problem.
Yeah, I can think of a really good example. I had a lady that takes Coumadin and knows she's not 65. Of course, Coumadin is a blood thinner. Well, she neglected to mention that she was also taking an antibiotic. And we couldn't understand why her blood levels were so off the wall when we did them. And we were like, we went through the whole thing. Are you watching this? Are you watching that? No aspirin, this and everything. And so then she mentioned, oh yeah, I forgot to mention that I was also on this antibiotic, which made her blood too thin. So in a case like that, it's really important to reveal what you're taking. Other medicines have very common side effects, but you still need to use them with caution. It's not that the medication is prohibitive, but you want to make sure that you're on top of the potential for high potassium if it's an ACE inhibitor and Bactrim, or there are other interactions that you need to watch. Even with some of the over-the-counter medications, there are seizure medications that really shouldn't be used with medicines like Benadryl or phenylpropanolamine, which is found in some of the cough medicines over the counter, because they tend to lower the seizure threshold. So you just have to be careful and really just check with your provider if you have any questions, or your pharmacist about interactions.
Well, so that's what I was going to say. It sounds like the take-home point is, one, supplements are medications, and two,
Yes.
your pharmacist is your BFF, is your best friend. They really can help you manage a lot of these issues.
And the other problem with supplements, though, is a lot of times they're not as closely regulated as your traditional medications are. And you may have a supplement that's sitting on the shelf right next to another one, where one will have this percentage and this will have this percentage. And there were some studies that actually showed that even ginseng over the counter, you may find that it had no more ginseng in the product than a placebo would.
Well, we have a lot to learn with this, and I think one of the
Absolutely.
important take-home messages, and we'll discuss this in the breakout session, the days of you just go to their doctor, they give you a pill, and you walk away and just take it blindly, really need to be gone. You need to be your own advocate and know what you're taking and why. And if you've got questions, ask your doctor or ask your pharmacist. Well, thank you very much. You've
Thank
been
you all for
incredibly
having
helpful.
me. Thank you very much.
Yeah, come my side.
And if you think about it like a book, there's a beginning, a middle, and an end, and often there's an epilogue. And that kind of planning of what you're going to do with your estate or what you're going to do with the funeral, that's kind of the epilogue. But there's this final act, right? There's this last stage, and we have to plan for that. And there's a lot of medical decisions that need to be made along the way. So I kind of think about it as having a plan A and a plan B. And plan A is you want to be alive and healthy for as long as possible. So all the things that we've just heard about today, such good wisdom for how do you stay alive, how do you stay healthy, how do you become vigorous, and have the most meaningful life possible. But one day you're going to get sick, and that sickness is going to end in death. And so you've got to take into account those things too. So plan B is, what am I going to do when I get sick?
That's very good.
So we discussed a lot about this ahead, and you talk a little bit about the 3 trajectories.
Right.
What exactly does that mean? It's not the trajectory of that kid flying across the sky.
The general trajectory is the same for everybody, the beginning, the middle, and the end. And for most people, so the American dream is that, you wake up alive and fine, and you go to sleep one night, and you're not here anymore the next morning. Most people don't pass that way. Death isn't a surprise for most people. There are 3 basic pathways. The thing that people think of the most is they think that, I'm going to have cancer. That happens for about 25% of people. Most people tend to have a chronic illness. They have heart disease or lung disease or kidney disease, and those are illnesses called chronic illnesses or organ failure, and they behave in a particular way. And then some people, as we heard from Dr. Dobin, get dementia, and dementia is actually a lethal disease or medical frailty, where your body is just so frail it doesn't work anymore. Those 3 different pathways have 3 different sets of kind of choices that go with them. And so once you kind of have an idea of what pathway you're on or what pathway your parents are on, you can start doing more specific planning. But until then, you really need a general plan. And that general plan should involve really good conversations about what's important to you in your life. And more importantly, who will make decisions for you if you can't speak for yourself?
Well, that was one of the things we were hoping to bring up, is that conversation is crucial.
Right.
I mean, you've got to be able to have that discussion with and in the right way. So you are familiar with something called the Conversation Project, and we thought it would be nice to share with everybody in the audience tonight.
The great news is that we don't have to reinvent the wheel with some of this stuff. And I noticed you gave a website earlier. The one I'd like to promote is called theconversationproject.org. And it was put together by a group of people, strangely enough, called the Conversation Project, who realized how important all of these conversations are. And they break it down into 4 easy steps. Get ready, get set, go, and keep going. So you can go online, and it's a way to bring up some of the really practical things, like you want to talk about it, but you don't know exactly how to talk to your kids about it. So they give you some one-liners about, do you remember this movie that we saw? I'm a little worried about that. Can we talk about it? And so they just give you really practical advice, and then they go through and ask specific questions to help you think for yourself about what kind of medical care you want, who you want to be involved in your decisions, who you don't want to be involved with your decisions.
That's a huge one, and I can tell you, my earliest memories of childhood, I had relatives die like crazy when I was growing up, and I can tell you, every year there was a funeral, and that's really, my memory of childhood is going to funerals. But there was a rock, and that rock was my father. My father managed it, no matter who it was in the family. My dad was the guy that managed it. Now I got later in life, and when my mom started to get sick, we had to deal with this issue, and she was dying. It wasn't a sudden thing. And we had to come to a decision, my brother, my sister, and I, and my father, and who's going to be making those tough decisions. And there are tough ones to make. And I've seen a lot as a physician where families haven't figured out who that's going to be, and it's a war, which ruins everything. The best thing is really to have a spokesperson. And my family, being the medical person, they defaulted to me. But it was at least, okay, we're going to follow your lead, we're going to agree to do that. And I think that's part of what you're talking about. You've got to have this settled. And I can tell you, and I'm sure B, you would say the same thing, as a physician trying to address a family, if the family is not working together on this, it becomes almost impossible.
Absolutely, absolutely.
I think that's a really important point. And thinking very carefully about, if you can't speak for yourself, who do you want to speak for you? And some people, it's really obvious. They've got, a long-standing relationship with someone, and that person has been there by their side, and they know exactly what they want, and they're the person who makes the most sense. But sometimes that doesn't make the most sense for people. And so perhaps you're someone who has survived their spouse, or perhaps you've got a spouse who is so close to you they couldn't stand to let go of you. One of the saddest things that I encounter is it's not unusual for me to talk to a family and find someone's quite ill and they might die soon. And I ask them about a medical decision that might be very challenging, and they say, I know he doesn't want to live this way, but I just can't bring myself to let him go. And then everybody suffers because the spouse is sitting there knowing that they're not able to enact the wishes that their loved one wants. The loved one is actually suffering quite a lot during that time, and everybody has to kind of watch that difficulty go through. So in that kind of situation, if you've got that kind of relationship with somebody, it might be much better to say, you know what, I know that we're just so close, you could never make that decision about me. So what if I have my brother do it? I know it'd be hard for you, so let's have my brother do it, or let's have the guy who's the best man at our wedding do it.
That's a good point. Yeah. I mean, because you may not like your spouse.
Well,
I'm not dead yet. I'm not sure I'm giving my sister the right to do this. No, I don't. If it was up to my sister, I'd be gone already, I promise you.
there might be a reason all those people died in your childhood. You were going around with your little BB gun.
So this is a tough one. Can you give people some advice on how to actually start this conversation at home?
I think there are a couple of things. One is just the most obvious one is kind of say, you know what, I'm thinking about my future. Would you mind talking to me about some of the things that worry me? Another way, there are all kinds of reference points in our culture. There are really good movies out there that happen all the time, and suspiciously people pass away all the time. You can say, you know what, I went to a funeral last week, and I went, and especially as you get older, my mom keeps telling me, all I do is go to funerals. And you say, she was just so brave and so courageous. Can we talk about how that went? And invite them into a conversation. And if you have a guide like the tools that are offered by the Conversation Project, they kind of guide you through the things you should be thinking about in terms of what level of quality of life are you willing to deal with? Are you willing to go to a nursing home if you could never come back out? What would it be like if you couldn't talk or you couldn't recognize your family members anymore? And those are the kinds of things you've got to have a conversation about, because if you wait until it's too late and you're in the emergency room and your best friend, the vascular surgeon, comes along and says, I don't know if this is going to work. If that's when you start the conversation, it just doesn't go very well because you just don't have time to process it all.
Absolutely.
So who starts that conversation? Is it the adult who's nearing the end? Is it the child that has to be the one that manages it? Who's the one that's supposed to start that?
The brave one.
Interesting.
Yeah, it's the person who recognizes it, and I think this is one, you hear about don't ask, don't tell in the military, but I think in this situation, it is one of the biggest don't ask, don't tell. That if you say, if I don't say anything about it, you won't say anything about it, and we'll all be fine. And as medical professionals, we kind of do that too, because if I don't bring it up as a doctor, and my patient says, oh, well, he's not bringing it up, I'm not bringing it up, but you've kind of seen yourself slide, or you've seen your mother kind of decline, somebody's got to bring it up.
Right.
And so I happen to think it's the medical professional. And I think we should be talking about it all the time. Because at the beginning, you just have general conversations, right? You can have that conversation of, oh gosh, I saw her, have this particular kind of pathway, and I would never want that. Or I saw this happen, like that was just, if you've got to go, that's the way to do it. And just have general conversations, because that's even enough to get a good sense of what's going on. And then as more dramatic things happen, if you've got a loved one who's been in the hospital frequently, then you can start having more explicit conversations about, ooh, I was in the hospital, I was in the ICU, that wasn't much fun. I don't know if I would want to go to the ICU again.
That's a good segue, because you mentioned before when we were talking about the most and how this is utilized and how it might differ from other proxies for healthcare.
Sure. There are lots of ways that people come to first, you've got to come to the decision. So you've got to come to understand what's important to you and having that conversation. But then what's important is to write it down in some way. And so the first thing is if you want your decisions to be made by anybody except your next of kin or the person who most people would look to next, you want to write that down. And that's called a durable power of attorney for healthcare. And that gives someone else the rights. If I said, you're my best friend now and I want you to make this decision, I'm going to write down on a piece of paper that that's what I want. And that's a very important document. There's another document that people have. They're called living wills. And they were very popular for a while, and we thought it was a really good idea. And you went through and you said, I want to be on a ventilator or not, or I want a dialysis or
We
not.
have a checklist.
Exactly. And in some circumstances, those are helpful, but generally what I find is people do them before they know what might happen to them. And so the choices they make often don't work, or when you need it, it's in a lockbox someplace, or it's just not as helpful. So there's kind of a program that's being developed, and it's either called Physician Orders for Life-Sustaining Treatment, or in Maryland, it's called the Maryland Orders for Life-Sustaining Treatment.
Okay.
And what this is, it makes it different from a living will, is in a living will, it's kind of like, one day something might happen to me, so I'm going to write something down and hope that it's the right thing when that day comes. And there, you can see why that might not work out so well. So this is something that's reserved for people who are really sick. It's after you know, hey, you know what? I have a pretty bad heart, or I've been diagnosed with cancer that spread, or my mom's at the beginning stages of dementia and it looks like something like this might happen. So when you get kind of an idea of each of those things have a different sets of choices about them, and this MOLST form is not just a piece of paper that I've written, it's an order from a physician. And it is transferred from one institution to another. Because if you write an order here,
Right. It doesn't
this
stand.
it doesn't go with the patient to the nursing home. A MOLST is an order that is able to be transferred from one facility to another facility. And people who are in ambulances, EMS workers, have to honor that. So if you've got that order there handy, you know what the EMS people know exactly what you do want and you don't want. And it's a very generic form, because you can say, I
So
absolutely...
you can get it offline.
Yeah, well, you get it from your doctor, because it has to be signed by a doctor.
Okay.
And it's a law that's gone into effect now in Maryland, where now in January of 2013, they are available. And starting in July, all hospitals, nursing homes, hospices, rehabilitation facilities, anybody who's one of those facilities have to be offered one of these forms.
Very good.
Well, I struggle with this one. I must confess. I don't like to let go.
Yeah.
And as a surgeon, I don't ever like to give up. And I've certainly watched patients that have been patients of mine for a long time,
Right.
and have really struggled. And I watch families who cherish every last breath.
Right.
And I think and you can help me and help all of us, I don't know how to define. I mean, the state is trying to help me and all this to try to find what's the appropriate way. There's never going to be a cookbook
No.
for when's the right time.
No.
There's never going to be any rules and what's the right or wrong way.
Right.
And it's an incredibly personal
Exactly.
experience and the right way to do it. And I look for guidance on how to do this. And I think hospice and palliative care, those are things that come up that we talk about in the hospital that sometimes have very negative connotations and very positive ones. And so maybe
Only
you
from
can
vascular surgery.
only well, we look, and I will tell you this as physicians, and you guys probably know this, and we need to get past this. We look at death sometimes as failure.
Yes.
I mean, that is the mentality I certainly have as a surgeon, that if there's a patient of mine that doesn't make it, I failed. And that's hard, and it's hard to help families make those tough decisions with care, because in the process of helping them make those decisions, I'm admitting my failure for not being able to get them through that situation.
And I think that's a really good point, and that's when it's time to really step back and take the long view. And this is a more philosophical kind of a conversation of, so before, let's just go back, and how many of you really remember clearly what was happening in the 70s and 80s? Most of us have a pretty good memory of what was happening in the 70s and the 80s. At that time, we made huge strides in healthcare. Because before that time, there were people who were dying, well, their bodies were still in pretty good shape, right? They were dying, but they had a big heart attack. Well, now what happens when somebody has a heart attack? We rush them into the cath lab. And so before, there was a time when people died, we say prematurely. Their bodies were still in pretty good shape, but one bad thing happened and they couldn't recover from it. And we now have lots of tools to help people pass that. If your body's in pretty good shape, you can overcome lots of things. But now we've reached the point in medicine where the whole body can be towards the end. And you can't make up for the whole body reaching its end. It's the normal end of the human life.
Right.
And all of our big stories kind of revolve around that. I mean, vampires are a big deal, right? Why do we have vampires? They're people who are afraid to die. Why do we have Harry Potter and the Sorcerer's Stone? Because there's a story of bad things that happen for people who pretend like death isn't going to happen and they try to live forever. And so there are times when if somebody is in a bad accident, of course you want to resuscitate them. You want the most important, the most aggressive things that you can do because their body isn't really ready to let go yet. But everybody's body comes to an eventual end. And if we can stop denying that, we can just say, you know what, how do I plan for the best ending ever? I want to live a great life. I want it to be joyful and full of meaning. And I want to have a great relationship with my physicians. And when it's time to say goodbye, say, you know, thanks for doing all that great work. I've had a great time. I really appreciate the work you've done. And now it's time for me to make a graceful exit.
Yeah, I like the way you said that, the best ending ever.
Well, why don't we end on that, because we're getting late. I told you I wasn't good at this. It's just not my thing. And we'll get into more of the difference of hospice and palliative care in the breakout session.
Great.
So thank you very much.
Thank you so much. It's been great. Thanks so much.
Why do I feel like Debbie Downer all of a sudden?
Well, we ended on that note. It was a little difficult, but I think it was a good discussion. I mean, wouldn't you agree? Thanks to all of our guests tonight. You really brought some very informative information, so thank you.
So this is an interesting evening, and then if those of you who have been through the show, we've done 12 shows now on various different topics. And every one of those shows, somebody in the audience may or may not have to deal with that problem, whether it's urogynecology, which really wasn't that applicable to me, but there are other things, cardiac issues, which handle a lot of people, but not everybody. This is the one show where it applies to every single person in this room.
Absolutely.
And whether you're in this room at 20 or in this room at 90, what you learned tonight are very important things that you need to take home and share with your relatives and friends. And so I hope this, if nothing else, started a conversation with you on what we try to do. Now, every time we do one of these shows, we try to think of the 3 pearls that we learned. So I'll throw to you first.
Well, I think they're good points. Dr. Bryant, you brought up a good point about just medications are supplements are medications, and I think that's a really important take-home message for everybody here in the audience. And I was very happy to hear that dancing, playing games are helpful, because I do that all the time.
Is it time to dance now? I'm working on my mind right now, you guys.
But again, I think, Dr. Lukas, you brought up the best point of all, that don't wait to the 9th inning to have these discussions. You really need to be strategic about your planning.
I think for me, the first one is I feel better about knowing where my keys are. That's pretty comforting. That's a good one for me. I think another one for me is really important is the issue about actually taking the whole body as a whole and thinking about my mind, my body together and looking for going future. I really not consistently done that. And I think the last one for me I still struggle with, and I will confess it's still a start for me, is this whole end-of-life planning. It is a very difficult struggle for me. My father, for instance, started the hospice program with my mother in my hometown, and so it's been a big part of my family, and I'm still struggling to get there. But I think I will continue to work with it because it's really important. But I hope you guys have your 3 and that you found tonight actually being very helpful. So, what do we end the show with? It's your turn.
It's my turn.
It's your turn.
What do we say? We say good health doesn't happen on your own.
It takes teamwork between your docs and you. Thank you all very much for coming out.